Hello and welcome to this special on ETV Bharat. India has been facing an unprecedented second wave. And what can be done from the policy front? At the same time, what is the kind of precautions that we need to take? That has been in the minds of a lot of people who have been on the field and trying to mitigate the crisis at hand. To discuss more about this, we have an empowered panel of guests who are joining us and who will give us insights as to how probably India can face the current situation. We're joined in by Dr. Ranu Dhillon, instructor and global health physician at Harvard Medical School. He served as special advisor to the president of Guinea for Ebola, which involved working side by side with the country's national Ebola coordinator to develop the strategy and organizational structure for controlling the epidemic as well as managing its day to day execution. Welcome to the show, Doctor.
Thank you.
We have also with us Dev Bhaktani Sri Krishna, who's the founder of www.patientknowhow.com, which curates information on N95 masks and Hifi mask alternatives. Previously, he was CTO and co-founder of Tropos Networks, which build wireless mesh networks for citywide Wi-Fi access, including utilities, police department control, and internet service providers. Welcome to the show, Dev Bhaktani.
Thank you.
And we also have with us Dr. Adrish, and Dr. Adrish Bhadra, in fact, joins us from Madhya Pradesh. He's working with rural sector in Madhya Pradesh and delivery of primary health services over there. Now, the first question, of course, goes to Dr. Ranu Dhillon. The question over here is not about having good medical knowledge and good medical facilities. It's also about policy decisions. And you have seen the kind of situation India is in. What would be your first advice to the government?
Yeah, I think right now, given the catastrophic transmission that's happening and the overwhelming of the not just the health system, but even households who are caring for sick family members and who are having family members pass left and right, what really needs to happen is a comprehensive and very aggressive response. And so far, a lot of the discussion has been around bolstering treatment capacity. That certainly needs to happen, but that will take time, as will vaccination. So those efforts need to be made, but we also need to be doing a lot more to slow down transmission. Transmission can increase exponentially. Increasing resources to manage more people getting sick can only really happen incrementally. And there's a lot we can do, which we'll get into, using masks, deployment of rapid tests, and also doing better home-based triage and management of people who might be infected with COVID to try to slow down transmission and manage the crisis in a more comprehensive way. And then there's also the question of how, if and how to implement restrictions and variations of lockdowns. And I think transmission may be at a point where that would be wise from the standpoint of trying to slow the pandemic. But at the same time, that has to be done in a very humane way, whereby people are not being left without social and economic supports that in its own way would create a separate and similarly problematic catastrophe.
Well, Dr. Dhillon, now you have in fact had 15 years of experience on this, and you've been managing health systems in low and middle income countries. Now, with regards to India, probably we cannot define India when it comes to low or middle income countries, how you can put them in one general category. Over here, what we are looking at, probably different areas of India have got different responses. So some parts of the country might, respond in like a high income country wouldn't respond. Some areas in the country might actually be what would be described as low and middle income regions. So there is a varied, diverse response also present in this country. Some states have been doing well to manage the crisis, some have not been. So it's going to be very difficult when it comes to actually having a uniform policy. So when do you think this is going to be the challenge for the government because of this not so uniform way of going ahead and responding to a crisis?
Well, from having worked in various parts of India myself, including Jharkhand, as well as in some of the relatively better off areas around, let's say, Hyderabad, and also working with Dr. Adrish in rural Madhya Pradesh, of course, there's a huge variation. So a one size fits all is not really something that's possible nor wise. And so much of what has to happen has to be tailored to the local areas. But from the standpoint of stopping transmission and dealing with COVID, there are some universalities that are not just generally applicable to transmission in India, but even globally. And that includes better masks that can protect people when they're in crowded areas and indoors from emitting infection as well as receiving it. And that's something that applies to rural Madhya Pradesh the same way it will apply to a wealthier neighborhood in Delhi. And so there are aspects like that that can be applied across the board. Similarly, rapid diagnostic tests. These are tests that ASHAs, community workers, and even people themselves can administer on themselves to determine if they might be infected and capable of infecting others. And the idea is if you're doing these tests on yourself, ideally every few days, if you're finding out that you might be positive, you can then take the measures to isolate yourself. And of course, if you start having symptoms, you can then pursue care before things get much worse. That's something that can apply across the board. I think the things that are gonna have to be different and done in a tailored manner is going to be, how do you create the systematic approach to implement this on the ground? So whereas in areas that have maybe a better technology in place already, better infrastructure in place, maybe communities where people have resources and can manage some of this home-based triage and isolation and going to get care when they need it on their own. In an area like rural Madhya Pradesh, and Dr. Adrish will talk about this, we're trying to think about how to create a systematic response where we're proactively reaching rural villages, being able to identify who might be infected, facilitating isolation, but then also doing things like home-based pulse oximetry to figure out who are the people who might need higher levels of care, and doing that in a systematic manner that really interfaces on the rural, town, and urban center health system, and trying to integrate what happens across the delivery chain. So again, things need to be tailored in terms of implementation, but the principles of how to slow transmission and how to manage cases is universal across the board. And I think so policy can be developed that can envelope that, and then the particulars of how to execute on the ground is going to really be where state level, and I would even say more so district and block level officials will be in the driver's seat to really drive through how we get this done. And of course, tools can be developed that can be applied across the board.
Well, we also have Dr. Adrish Bhadra, who's in fact joining us. Adrish, how do you see the situation in Madhya Pradesh? Because we have seen it being one of the worst affected states. But when it comes to implementation policy and things like that, how is the ground situation at the moment?
Well, I specifically work in rural Madhya Pradesh. So in rural Madhya Pradesh, our observation has been during the last wave of the pandemic, the villages, the smaller towns, such as Raugarh, where we work, those weren't that badly affected during the last wave. But this time around, during the second wave, I think COVID has penetrated deeper into the rural pockets. And our observation is almost every second or third household in villages, if you go there, you'll find symptomatic patients. Now, the challenge is in cases like these, the pre-existing healthcare infrastructure is already poor. It used to be overburdened anyway, and patients used to be referred to higher centers for better care, better management of patients. Now, the challenge is on an overburdened system, the pandemic has caused a lot of pressure. And to add to that, the uptake of preventive measures in rural areas has been really poor. There might be some misconceptions involved. And also, we have noticed that the wrong precedents have been set for people living in the rural areas, given the election rallies that have happened, the examples that have been set by a lot of politicians. So the last few months have been actually disastrous in terms of uptake of preventive measures because the wrong examples have been set. So that partly does contribute to the challenge of tackling pandemic. And if you talk about testing, from what we have observed in the public health facilities, testing is available in the form of rapid antigen tests and RT-PCRs. It has been capped to some extent by the government. But the major challenge, as we have spoken to some block medical officers over there, what we have realized through that conversation is that the challenge really lies in utilization of the facilities, the testing facilities that are available. People from the villages are very scared to get tested for COVID, maybe because of the reason that they have to go into, because they probably believe they have to go to quarantine centers, or the risk, the economic risk that comes with home isolation. And such misconceptions have to be cleared. These tests have to be therefore provided from, door to door to improve the uptake of testing. And a lot of information, education, and communication has to be done regarding utilization of well-fitting masks, as Sri will point out eventually during this discussion. So that has to be there. And above that, I think healthcare infrastructure needs to be improved. Supplies such as oxygen and medications have to be improved, and they have to be maintained over the course of the pandemic.
Well, in fact, both of y'all spoke about the most important aspect of trying to control this transmission of with regards to the mask. And so let's now, in fact, get Dev Bhaktuni Sri Krishna into the discussion. Now, what is this concept of hi-fi mask that we have been looking at? You've been promoting it also, and how helpful is this fight against COVID-19 by using these masks? And what is the availability of these masks in the country as of now?
Excellent question. Hi-fi masks include N95 masks, but they also include other masks like from Korea called KF94, FFP2 in Europe, and some versions of KN95 from China. So these are already available in the market, but the usage is not universal. And I think this is the most important part. There are also elastomeric versions of these masks. And the basic principle is that when we breathe in and out, in an hour, we are breathing somewhere between 360 liters of air to 5,400 liters of air per hour. So our lungs are extremely efficient at sucking in the air in the room and then exhaling. And so that's how we live. But at the same time, that means we are also absorbing all the things that are in the air. And COVID accumulates it travels in the air, and then it accumulates in indoor settings, especially. Even outdoor possibly too, but more so indoors. And so in poorly ventilated areas, which most places in the world they're not very well ventilated. They are going to, the COVID, someone who's infected is going to breathe out this COVID all the time, and it'll start accumulating just like smoke. If someone is smoking in the room, how does the smoke start staying in the room, stagnating in the room? That's exactly what's happening with COVID, essentially. So as a result, we need to protect ourselves from this using these hi-fi masks, which we are calling hi-fi stands for high filtration and high fit. So it's just a shorthand. We're saying, but these are products that are already on the market. They're available throughout the world. There's actually not much of a shortage anymore. There's actually a surplus. So really now it's a question of people needing to buy them and use them and distribute them in a widespread manner. In fact, Germany has already done this. They have made it mandatory for everyone in the country to use these hi-fi masks whenever they are interacting with people in the public.
Mm-hmm.
So.
But Devbhaktani, one very interesting part you've spoken about is the kind of numberings and codings that you've spoken about with these masks. Yes. I don't think so. Like even a person like me, I have some knowledge about it. All that I know is an N95 mask. Yes. And this kind of, could you in fact enlighten more on this? Because I don't think so. A lot of Indians actually have an idea about what is the kind of mask available and what is actually good for them. Because most of the times when we go to a place, we just ask for an N95, and yes, that's the only thing, or that's the only standard that we know about. Yes. Nothing else further to it. So could you just enlighten upon what all is available?
Absolutely. N95 is a US standard designed by the Center for Disease Control, National Institute of Occupational Safety and Health, and it is a very rigorous standard that goes all the way from the design of the mask to the manufacturing and the quality verification. So it's an excellent standard. Any N95 mask, the filtration, they focus a lot on the filtration media, how well it filters the small particles. If you have a cloth mask, a lot of the small aerosol particles that we are exhaling and inhaling, they go right through it. You can't see them, but they're small enough, less than a millionth of a meter, and they'll go pass right through it. Maybe at best 50% filtration in best case, more like 20%. Whereas N95 mask is designed to filter 95% of those particles across all particle sizes. And the way it does it, very ingeniously, is it has a material that has an electrostatic charge inside the material. So these masks that I'm showing here are examples of N95 masks, and they have a material that it is charged material that traps the small particles, just like in the dryer. And if you have a clothes dryer, and you have socks that stick to the blankets, if you're familiar with that. And so it's charged, and that's why it works to stop the virus. And so, but it also requires it to be fit across the face, so it's not leaking around the sides. It's equally important. If you have an N95 mask, you're wearing it loosely, it does no good.
Okay. And so that's very important because most of the Indians don't tend to have that tight fitting onto their face, especially
Yes.
when it comes to masks. And some of them say that I was, in fact, wearing a mask. I don't know how did I get the infection. So
Yes.
probably this could be one of the reasons behind it.
Absolutely.
Now, the other big question that we have is that now this question about double masking that has been happening. A lot of people have
Yes.
been asking people to go for double mask. Now, when it
Hmm.
comes to double masking, is it safe when it, or because a lot of people complain of feeling suffocation,
Hmm.
they find that they're not able to breathe as easily as possible. But at the same time, that's the only way, is what a lot of experts are saying. So, what about this double masking phenomenon, and why is it this instruction given out right now, especially during this COVID pandemic?
Yes, double masking is a stopgap concept. It is I think if you have access to N95 or KF94 or FFP2, I would immediately prefer those to double mask, first of all.
Okay.
If only you need to use double mask if you have nothing else available, and you must get something that will filter the particles. And even when you do it, it doesn't work as well. Real world tests have shown it filters in human subjects around 75% of the particles, which means that 25% are passing through, which is a lot compared to 5% of the N95. So, but in places where it's not available and you must do something right away, speed is going to be more important than waiting for the best thing while you're waiting for the best thing. So the concept is you need to take a surgical mask like this that fits. It has a 3-ply surgical mask has some of the same material that's used in an N95 mask in many cases. So you put it on, and then you put a cloth mask on to make sure it fits tightly. So you're basically solving the problem in a kind of a ad hoc way. You're getting filtration with the surgical mask, and on top of that, you need to put a cotton mask to make it fit to your face. So it doesn't work as well as the other manufactured masks, but it's something you can try. And it's not, and also for breathability, it's not well engineered for breathability. These N95 masks are engineered for filtration and breathability.
Okay.
They have a maximum pressure drop between the inside and the outside that they're designed to achieve. Whereas the double mask is just a homegrown solution. So, again, it's a trade-off. If you have nothing else, you can consider it, but better to buy a N95 or say equivalent.
All right. Let us go to, in fact, back to Dr. Dhillon. Now, in the area of epidemic testing, also, you have a vast experience. And in Indian scenario, you see there is a lot of testing that is happening, but a lot of false results are also coming in. We don't know whether tests are happening properly also at times. We had a situation where a person who went to one testing center got a positive result, who went to another testing center got a negative result. So there's a lot of confusion with regards to testing as well. So especially, how do you look at the Indian scenario, and how can we streamline testing for better results?
Yeah, so there's different ways of getting tested and different testing modalities. So, for example, RT-PCR, in a lot of times is considered what we call the gold standard. It will miss fewer cases, but there is a false negative rate with even RT-PCR. There's also a high, what we would call false positive rate with RT-PCR, in that someone who, for example, I took care of some patients just a few hours ago who had COVID months ago. And some of them, they'll still come back positive on RT-PCR because it'll still pick up some of the fragments of the RNA material. So every test comes with certain pros and cons. RT-PCR works well when you're trying to confirm diagnosis, so to be sure that the person is infected, especially when you're thinking about isolation, triaging isolation beds, and also thinking about administering treatments. Now, the thing is, RT-PCR cannot scale to the extent needed in a pandemic where many of the chains of transmission, if not most of them, are unknown. So, for example, we saw the same issue when we dealt with Ebola several years back, where, Ebola, people talk about these symptoms of people having bleeding from the mouth and et cetera. But most Ebola patients don't have those symptoms. Most have fever, chills, something that sounds like malaria, pneumonia, other common illnesses that are there every day. So then the problem becomes, if you don't know where all your transmission chains are, then anyone coming with a fever could potentially have had Ebola. Now, the problem is RT-PCR, the challenge we faced with Ebola some years ago, RT-PCR could not be scaled to really screen all those people who had fevers who may be infected. Now, let's look at how that plays into the COVID scenario in India. You have transmission chains that are completely unknown. And the challenge with COVID is, additionally, it's not just people who have symptoms, even people who have no symptoms could be carrying the virus and breathing it out and infecting others. And so there's just no way RT-PCR is going to be able to scale to that extent. This is where other tests, such as the rapid antigen tests that Dr. Dreech mentioned, could be a huge game changer. These are tests that give you results very quickly. They do not require the specialized laboratory personnel and equipment that's needed for RT-PCR, and that limits the ability to scale it. And these tests can be deployed on the field. So you can train ASHAs, you can train even other community agents who are part of the government structure, or NGOs, or other groups operating locally, to then administer these tests. And like I said, even patients themselves can be trained to administer these tests on themselves. So these tests do have a little bit of a higher false negative and false positive rate. Now, the thing is, the false negative rate from the studies that have been done so far seems to be in patients who, generally speaking, are not as infectious. So the people who have higher loads of virus tend to be more accurately diagnosed by these tests. Second thing is, these tests work well. Like I said, you have people who have no symptoms who might be infected and not know it until they infect others who then become sick. So one of the values of this test is that if you can ideally do it every couple of days, even if somebody's false negative on Tuesday, when they retest on Saturday, you find out that they are infected and possibly able to infect others. So using it serially is one key. And then when you talk about false positive rates that are a little bit higher with these tests, that's something that can be offset by basically anyone who's testing positive. You either test them with another rapid test that targets a different antigen on the virus, or you confirm them with PCR. And so in this way, you can integrate these. No test is going to be 100% perfect for every situation all the time, but you take these modalities you have and you can create an integrated strategy. And that way you're able to test widely, which is what you need to do in a public health crisis as what is going on, and then be able to use PCR capacity to then confirm cases that then will be managed accordingly once the confirmed diagnosis of COVID is there. Even when RT-PCR can't be scaled effectively to even confirm all those cases, you can still presumptively isolate people if they're screening positive on rapid antigen tests. So there's a lot of ways to do this that can work effectively. Now, there's always going to be challenges of implementation, execution. There can be lab errors. All of that can be there. There's no way to, wave a magic wand and deal with those issues. But I think what you can do is create a systematic approach and basically provide support where it's needed so that the execution happens the way it needs to. And this kind of goes back to what we talked about earlier, where execution has to really be managed and done in a way that works in each locality. And so I think there's ways to do this. And I think with the proper support and a clear strategy, testing can be expanded. But I think the key piece will be really getting rapid tests into the fold and scaling them up exponentially from what's being done now. Because at this point, we really need to be testing ideally almost the whole population on a routine basis. And we're very far from that. At this point, we're still, catching just a fragment of the cases that are probably there.